Happy to be here. As Vicki said, I am a nephrologist. I am part of a pretty sizable private practice here in Birmingham, Alabama. We are a busy practice. We see a lot of patients, and as probably a lot of you guys where you are in the world know that this is a big problem and one that is often underappreciated, perhaps sometimes, especially early in disease course. So we are going to be talking about chronic kidney disease today, and specifically screening and some early management. I'll provide a few definitions. We'll discuss what techniques we have for screening, hit on, some frequent causes of CKD. And as far as management, I will be focusing primarily on some hypertension management strategies. Obviously not going to have near the time to get exhaustive as to management strategies for different causes of chronic kidney disease. Please, feel free to, as Vicki said, raise your hand, ask a question in the chat, interrupt me if something's burning or not clear, or perhaps I misspoke. That will not be offensive to me. So what do we mean when we say chronic kidney disease? Okay, so the official definition of chronic kidney disease, or CKD, is defined by the presence of kidney damage or decreased glomerular filtration rate for 3 or more months, irrespective of the cause of that. Sorry, let me clean up my screen a little bit. Okay, and so that 3-month period, is important as to make an appropriate diagnosis of chronic kidney disease, and that's in comparison or in contrast to what we classify as acute kidney injury. No longer acute renal failure. Acute kidney injury is the term that is preferred. And acute kidney injury is defined as a rise in serum creatinine and, by inference, the decline in GFR that has occurred within hours to days. Okay, and then there's another term, acute kidney disease, that I'm not sure if I've ever used, but essentially it means that interim period between an acute or rather sudden change in kidney function and that 3-month window where we say that, okay, now this is chronic, more permanent damage that we may not expect to improve very much. So you're a primary care physician or other physician or other provider, and a patient comes in. What are some of this list is what are some of the clinical signs that may cue you into a patient maybe having issues with their kidneys, or at least maybe would raise some flags for you, or some questions to, do I need to do a little bit more investigating to see what this patient's kidney function truly is. So these things like edema, very often in the ankles or lower legs, sometimes, periorbital around the eyes. Sometimes these patients just may say, I've gained 30 or 40 pounds over the last few weeks. I'm not eating any more than I am. I just feel like it's water weight. Obviously, hypertension, not only the presence of hypertension, but any changes in hypertension. So if you've got a patient that you're familiar with and they've got a diagnosis of elevated blood pressure, and you've had them on 1, maybe 2 medicines for quite some time, and now suddenly their blood pressure is not near controlled as you're used to seeing, that could be a clue. Obviously, changes in urine output. If patients come in and say, I'm just not peeing near as much as I think I should be. I'm drinking, I'm staying hydrated, I'm drinking fluids, but my volume of urine has decreased. And then some just kind of vague complaints, weakness, fatigability, some nausea, some anorexia, some pruritus. All of these can be subtle complaints that patients may have that should perhaps cue you in to do I need to look harder and closer into what their kidney function is? Now, obviously, these can be very vague. They can be present in a number of different medical issues. So these complaints in and of themselves do not necessarily diagnose chronic kidney disease, but it could be small, subtle clues to get you thinking a bit more. And again, however, and as that sentence at the bottom says, that most newly diagnosed cases of CKD do not have any physical signs, okay, and are more often made on with recognition of changes in blood work. All right, so how do I know how well my kidneys are working? All right, so we need to know what the GFR is, okay? And GFR stands for glomerular filtration rate, and that is defined as the volume of fluid filtered from the renal glomerular capillaries into Bowman's capsule per unit of time, all right? So if you can see on the schematic I've got there, we have our afferent arterial, so that's blood coming into the kidney. It enters this web of capillaries called the glomerulus that is surrounded by an open space called Bowman's capsule. Okay, that blood is filtered. You get, essentially, that's the beginning of the formation of urine. So you get the movement of toxins, waste products, electrolytes, a whole number of different things into that Bowman space, which is the beginning of the nephron. And then what blood is left leaves that glomerulus from the efferent arterial, okay? And the rate at which that fluid is filtered from the capillaries into the nephron really determines, how well a kidneys are working. So how do we measure GFR? Okay, and I think this is a very important concept to be aware of, okay, because it can be very difficult. And honestly, in the clinical setting, we are truly not measuring a GFR, okay, because the gold standard way to do that is to determine the urinary excretion of inulin, which is a molecule that is 100% filtered from the blood space into the Bowman's capsule and is neither secreted later down the line in that nephron, nor is it resorbed, okay, as it treks through the nephron. So therefore, the amount of inulin, you can give a predetermined amount of inulin in a patient's IV, and you're able to measure how quickly that inulin is found in the urine, and based on the amount that is excreted and the time it took to do it, that is the patient's GFR, at least at that time and in that moment that the test was done. I don't think I have this on a slide, but it needs to be remembered that GFR can vary in minutes to hours to days, okay? So a test like this, or even a GFR that's calculated based on other blood tests that we're going to discuss here in a second, is only what that patient's GFR was at that moment, okay? Which is another reason that to diagnose chronic kidney disease, you want to see a reduction in GFR or over a series of time of 3 months, knowing so that you can say that you just didn't catch a patient on a bad day, okay? Obviously, doing it this way is cumbersome, doesn't make any logistical sense to use this method in our patients in the office or in the hospital for that matter. So instead, we estimate the GFR using measured serum creatinine and sometimes some other newer biomarkers, and then some rather complex equations, okay? And the most common ones, historically, the MDRD, or the modification of diet and renal disease equation, and also the Cox-Krafft-Gault equation, okay? So what these equations tried to do was take a known biomarker, in this case, serum creatinine, and then it put into account a patient's age, race, height, weight, sex, okay? And in doing so, that equation would produce an estimated GFR based on those factors. That's often why there's still many labs when you order basic chemistries that they will report two different GFRs or estimated GFRs. One will say African-American and one will say non-African-American. There is less controversy in that now as it's become more and more accepted that race shouldn't be taken into account when doing this. So the now accepted equation to produce an estimated GFR based on creatinine levels is this 2021 CKD EPI equation. For the practitioners that are here, you may have noticed that your lab no longer gives you a African-American and non-African-American different eGFR. If they don't, that means they are using the 2021 CKD EPI equation. If you are still getting those two different estimations of GFR, that lab has not yet switched to this new equation, so just be aware. And again, the biggest difference in that is that race is no longer considered a variable in making this calculation. So what are some of the limitations to using measured creatinine to produce this estimated GFR? Well, one of those is a variation in creatinine production itself. Patients who are on special diets, such as vegan diets, who are on supplements like, creatine for muscle building, or on high protein supplements, other workout supplements can cause variations in this equation. Obviously, if you are taking a creatine supplement, that is a very similar molecule to creatinine, and the resulting estimated GFR will underestimate your true kidney function in much the same way. If you're on a very low protein diet, a vegan diet, and therefore not producing as much creatinine as other patients who are of similar age, size, and demographics, so to speak, your GFR will underestimate what your true degree of renal function is. Okay. Also, reduction muscle mass. So if you've got a patient who is missing a lower leg, you have to take that into account when in comparing what their measured creatinine is in this. Is that normal or abnormal? Creatinine also is secreted at the more distal end of the nephron. So it is filtered fairly well and fairly freely into Bowman space, but it is also secreted later on, which is why it is not the most perfect biomarker to measure GFR. And then also, as I was kind of mentioning, it needs to be at steady state. Okay, so if you have a patient that is in the midst of an acute kidney injury and therefore have a steadily rising creatinine level, that a point in time measurement of their GFR will actually be an underestimation of what their true GFR is. And much in the reverse, if you've had a patient who has sustained an acute kidney injury event but are in recovery mode and that creatinine is going down from one day to the next, the estimated GFR produced on any given day will overestimate, or did I say that wrong? Yeah, will overestimate or underestimate what their true GFR is. So overestimate, and when the creatinine is rising, underestimate. See, this is where I get myself. I'm just talking myself in circles. It will overestimate if we're in the beginning of an AKI. It will underestimate if we are in the recovery period of an AKI. Okay, sorry about that language slip up. And then some of you may have heard of cystatin and C. It's a newer biomarker that's becoming more readily available, more used. It works in very much the same way. It's thought to be, I believe, less secreted and may not have as much variability from person to person due to some of the things I mentioned above in this slide. So if you ever see one or heard of that, that's why. I often will use it, not for every patient, but if I have a patient whose creatinine is higher than I think that it should, in the sense that I just have a high suspicion that a measured creatinine for this patient doesn't truly reflect what their GFR is, I'll often order a cystatin and C and make that comparison and see if there's a significant difference in that reporting. Okay, so initial assessment. So we have to make sure we make a proper diagnosis based on appropriate blood and urine tests to determine the eGFR. It's kind of as I was just saying. Again, to diagnose CKD, we need to see that the GFR is impaired or lower than we think it should be, and stable for 3 months. Remember, we want it at steady state, okay? And we also want to make sure we're ruling out an AKI. It is not uncommon for me to get an initial consult or referral on a patient who had a one-time reading of a creatinine that was higher than they had been historically, okay? And before I start, putting labels on these patients as CKD or going down that road or having those conversations, I want to do everything I can to make sure that we didn't just catch this patient on a bad day. All right. So a lot of this is down to taking a very detailed medical history. You want to not only ask for medical conditions or etiologies that are very frequent and common in patients who develop CKD, but also those that could be reversible and may give more indication to AKI. So hypertension, diabetes, obviously, long-term use of nephrotoxic medications, specifically NSAIDs. So anything over the counter for pain, arthritis, inflammation, with the exception of Tylenol, fits into this. Prostate issues, especially BPH, in an older male population, especially, they have a history of kidney stones, either recently or in the past. Do they have a history of heart failure, liver disease, et cetera? The list is very long, but the most common things being common, you at least want to hit on those. And then as you're doing that, in the back of your mind, try to think, could there be reasons that lab the other week or the other day that prompted this referral, or that you're seeing in real time, is something going on that suggests that that's an acute event, okay? This time of year, especially down where I am, it's 100 degrees. I've got patients who have been working out in the yard or in the garage. They're sweating, they're not staying hydrated. So do they have some volume depletion? Have they been started on any new medications recently? Bactrim is specifically as an antibiotic that can cause an AKI. Are they having an obstruction from a stone or worsening prostate issues? Have they just been in a car wreck or other things? Just again, it's just very detailed, thorough history to kind of try to clue you in as to what may be going on. Obviously, it's very important, if you can get your hands on them, to have past medical records. All right, whether the patient's been told they have kidney issues previously or not. Do you have labs that stretch back 2 or 3 years that show that something's been going on for some time? Okay, now we're just seeing progression of that. Or do you have labs that show 3 months ago things were completely normal and now they're very much not? Okay, those differences can drive your thought process as to what we're dealing with. Sometimes those records just aren't available, despite how hard you look for them. All right, so you get a patient whose GFR is low or whose creatinine is high. So what's the next step as far as kind of basic initial workup you can do on the first day? You absolutely want to look at the urine. Okay, the most important thing in a urinalysis that I look for is there a presence of blood or hematuria and or proteinuria. Okay, blood and protein should not cross the capillary glomerulus into Bowman's space, so that if there is any amount of blood and or protein in a patient's urinalysis, it should at least raise questions in your mind. Is this coming from a glomerular lesion? Okay, it doesn't have to be. Blood anywhere on the urinary tract, from the glomerulus down the ureters, out the bladder, through the urethra, out the body, a very small amount of blood for any reason will show up on a UA, obviously. So it doesn't mean it's from a glomerular source, but at least you have to ask yourself, do you need to do some more investigation? Okay, so if you find proteinuria, it's always important to know how much proteinuria. So you want to quantify that with a PCR. That stands for a protein to creatinine ratio. That is just a spot protein and a spot creatinine that's done on a single urine study. It used to be in favor to get 24-hour urine collections for this measurement. That can be cumbersome. There can be difficulty in getting accurate collections. And for the vast majority of patients that I see, a PCR is sufficient to give me a good estimation of how much protein may be spilled in the urine. And then also, just while you're doing it, send some urine electrolytes. A low urine sodium could be suggestive of pre-renal etiologies of kidney disease. Again, volume depletion, are they in decompensated heart failure, dehydration, these sorts of things. I do not calculate a FENA. I just don't find a whole lot of use in that, but some still do, and it's not necessarily wrong to do so. And then you want to get imaging of course. Usually a renal ultrasound is more than sufficient, and that's just to look for any anatomical explanation as to why a patient's renal function may not be where you think that it is. So we're looking for things like, stones, blockage, evidence of hydronephrosis, cysts, and specifically polycystic kidney disease can be diagnosed just with a renal ultrasound. It's not unheard of to get some sort of renal imaging and realize a patient only has one kidney. The other one is either congenitally not there, or obviously is just small and shriveled and probably has been since birth. Well, if you've got a single kidney, these estimations of renal function have to be understood in a different way. Okay, we hit on trying to correct any reversible causes, and if you feel like you've done a sufficient workup, that you've taken all the history, you've done the tests, and you've tried to reverse any reversible causes, and you're just not seeing any improvement in the patient's renal function, or you have any doubt at all, it's never inappropriate to refer to nephrology for an opinion and for assistance. Okay, so classifications of CKD. The slide on the left is kind of the more traditional one that you'll see in books and textbooks, and to me is a little antiquated, but it is what it is, and all it's showing is that as GFR declines, a patient's stage of CKD increases. Okay, what's interesting, and you may have noticed that they classify stage 1, they call a patient with a GFR above 90 as stage 1 kidney disease. Well, in my mind, that's pretty normal kidney function. I don't know if I'd tell a patient with a GFR of 90 that they have chronic kidney disease. It's one of the reasons I don't particularly like this scale. And also you may notice, and there's a lot of labs that will often not report a GFR above 60 to any specific degree. It'll say greater than 60. Okay, well, technically on this stage, a GFR of 61 per se is advanced stage 2 kidney disease and on the verge of being called stage 3 kidney disease. All right. And often these labs don't even bold or flag as abnormal or do anything to get a practitioner's attention until that GFR falls below 60. Okay. And so just, kind of be mindful that just because the lab says that it's in normal range does not necessarily mean that things are perfect. All right. And then as we progress down to 3A, 3B, 4, and then 5. The other thing I don't like about this slide is that I don't classify stage 5 as end-stage renal disease. End-stage renal disease means that the patient's renal function has declined enough to where they are chronically dependent on some form of kidney dialysis. Okay, I have quite a number of patients whose GFR is less than 10, sometimes 5, and they have not yet been started on dialysis because they don't have a need as of yet. So they are CKD5, not yet on dialysis, not end-stage renal disease. Subtleties, semantics to some degree, but something to just be aware of. Now, I do like this chart that's on the right. It's a little newer because I think that the color scheme allows patients to just kind of better visualize where we are. And then more importantly, it takes into account albuminuria or degree of proteinuria, okay? Because we know that the more protein that is being spilled in a patient's urine, they're higher risk of progression through these stages of CKD, okay? So you can have a reported GFR and you can have a measured degree of proteinuria, and you can point with a finger on this chart to a patient and show them where we're at. And if you see the degree of red, a patient with a GFR approaching 15 but very little proteinuria is in the same risk strata as a patient with a GFR of 50 and a lot of proteinuria. Okay, and so me personally, I think I get more understanding from my patients after a conversation using this particular slide. All right, so the frequent causes of CKD, obviously this is not exhaustive. There are many, but these are some of the more common ones I see. I highlighted hypertension because this is a hypertension talk specifically, and the management that we're going to get into on the next few slides is strictly going to be hypertension. But hypertension and diabetes go hand in hand in the sense that both of those disease processes over time are hard on blood vessels, and the kidneys are little more than bags of blood vessels. So it is by far the most common referral that I get is a patient who are in their 40s, 50s, 60s or above, have had at least a decade or so of high blood pressure and diabetes, and now we're seeing that their creatinine is rising, therefore GFR declining, and they get referred to me to evaluate that and help manage that. But have they had, it's important to know, do they have other evidence of vascular disease? Okay, so have, coronary artery disease is consistent with progression of CKD because it's, the same disease process, just in a different organ. Have they had previous AKI events that were really severe in nature? Were they septic 3 or 4 years ago and in the hospital and have a dense kidney injury, perhaps even on dialysis, and they may have recovered well enough to be able to come off of dialysis with time, but it goes pretty, to assume that there was at least some degree of permanent injury that happened as a result of that event. Obesity by itself is directly correlated with CKD. Cardiac issues, especially ones that produce decreased cardiac output, CHF, atrial fibrillation, other tachyarrhythmias, pulmonary hypertension, valvular disease, liver disease, autoimmune diseases. Again, we mentioned decreased kidney mass, but they have a history of renal cell carcinoma, and they've had a partial or total nephrectomy. Well, that's going to affect their numbers. Polycystic kidney disease, any cancer diagnosis, and then if so, what were they treated with? There are some specific chemotherapies that we know are associated with kidney damage, especially if you use long-term. And then chronic retention, you always got to remember stones, prostate issues, neurogenic bladders, just poor bladder emptying in an elderly female who's had multiple childbirths previously. So just that comes down to history and just kind of, you know, remembering that these things can over time negatively affect the kidney. So let's go specifically into hypertension and CKD. Hypertension and chronic kidney disease go hand in hand. Not only is hypertension likely the leading cause of chronic kidney disease. I say likely because it seems neck and neck with diabetes, and it sometimes depends on who you ask. But for today, let's say that the chronic hypertension is the leading cause of CKD. What's interesting though is as your kidney disease progresses, the blood pressure becomes more difficult to control. All right, and so it can be this kind of vicious cycle of blood pressure and kidney disease, and difficult to manage well. And then it's been estimated that 80 to 85% of patients with CKD also have hypertension. And I would say that number is probably accurate. That does not surprise me at all. All right, so what factors contribute to hypertension in patients who have chronic kidney disease? Okay, so patients who have CKD have a tendency to be a bit more sodium avid, so they retain more sodium in their kidneys. That leads to volume expansion. They also seem to have an increased RAS activity. That stands for renin, angiotensin aldosterone system. I have a slide on that coming up to get more into that. It's very important that you understand that pathway. If you have nightmares of that from medical school and haven't looked at it in a while, I'd go back and refresh the parts of that pathway, because very often the drugs we use to treat blood pressure are targeted at specific points in that pathway. Chronic kidney disease overall just leads to enhanced activity of the sympathetic nervous system. And in later stages of CKD, patients often will develop a secondary hyperparathyroidism. This can lead to hypercalcemia, which in turn leads to increased vascular tone and increased blood pressure. Much in the same way, ESA, so that's erythropoietin stimulating agents, things like Aranesp, Procrit, others that are often needed in patients who have anemia related to chronic kidney disease, can increase blood pressure. And then uremia seems to impair nitric oxide production, so also in that way preventing a substrate that leads to vasodilation. Okay, so we'll get into the management. As I said, adequate blood pressure management is crucial in both the prevention of CKD and in reducing the risk of progression in CKD. It's important to also quantify or be mindful if you're dealing with a patient that has CKD and proteinuria. That's a little bit of a different beast. I would say that a large proportion probably do, but not always. But it is important to monitor that as well, not only initially, but in time, okay? Because that is going to, outside of creatinine and GFR, we're also going to be tracking degree of proteinuria to let us know if we're making progress in reducing risk for these risk of progression in these patients. And I think I'd said not only is it present, but how much, okay? Correlated with progression, and some of the antihypertensive medicines that we may pick should be targeted to reduce proteinuria. If patients have zero proteinuria, we may use different classes of drugs that we might otherwise. The goal in reduction is is as little as possible is the answer. Okay, so if you can get them as close to undetectable in how much protein they're spilling, that's ideal. But if you can't do that, at least getting down to less than a gram a day should be a goal in mind. And then patients who present with nephrotic syndrome, so that's it's more than 3 or 3.5, depending on what you're reading, who you ask, grams of protein a day. That can be difficult. If you've got a patient that first time you see them, they're coming in with 10, 12, 14 grams of proteinuria, getting them down to less than 3.5 may be difficult, but that should be the goal. But if we can at least get a 50% reduction of where they started, we can feel at least pretty good that we're offering some improvement. Okay, so what do I pick? As you're aware, the not only number of classes of blood pressure drugs, but the drugs in those class, it seems daunting and very much overwhelming to try to pick a regimen for your patient. So, but I'll talk about the big ones, especially and that need to be often used in patients with chronic kidney disease, and the ones that I most often use. And at the end, I've got what I call Dr. Broom's cocktail, which is it's the drugs that I have found that if I'm ever given a patient with resistant hypertension or difficult to control hypertension, this is what I start them on, and I've had a lot of success with getting them to go. All right, so first line, not always thought to be the first line, diuretics, okay? Because it will be near impossible to get your patients at or near goal if you can't get them at or near euvolemia, okay? The way it was described to me when I was a resident by my attending nephrologist is if you think, if you picture your blood vessels as a garden hose and you've got a nozzle at the end, and that nozzle is closed, but the spigot's turned on, you can imagine how tight that hose can get, okay? Well, you've got to you've got to release the valve, and you've got to get some of that fluid out to make your vascular more responsive and able to reduce vascular tone and improve blood pressure. Okay, it's also important to remember that very often the first line of diuretics that are chosen, especially in non-CKD patients, are thiazides, hydrochlorothiazide, chlorthalidone, some of the others. It's often, I don't think, fully appreciated that a lot of those medications lose their effectiveness once the GFR falls much below 50. Some might say 40 or 30, but the take-home point is in patients with especially advanced CKD, a thiazide diuretic is not going to give you the benefit that you're looking for. And I very, very often see patients for the first time who do not have a GFR at or near 50 or below. Okay, so for me and for my patients, thiazides are not my first two. I often will go ahead and start with a loop diuretic, Lasix, Bumex, torsemide, whichever one you choose, up to you, but you get more bang for your buck. Okay, the other thing to remember is that the effectiveness of loop diuretics are directly dependent on a patient's GFR. Okay, loop diuretics are interesting that they are a threshold drug. You've got to get enough of that medicine where it works to have a diuretic effect. Okay, if a patient is not having a response, and by response I mean you ask them if they're peeing an hour or so after they take their diuretics, they should either say, "Oh yeah, doc, I'm going. I can't take it before I go to church. I'm not taking it after 5 o'clock in the evening. If I've got to go on a car trip, I'm holding it that day." Okay, you can feel fairly confident that whatever dose you have them on is having the appropriate response. If they say, if they hem and haw and say, I don't really know, they're probably not at a sufficient dose, and you probably need to be pretty eager to push that dose. Okay, this is one of my mantras, especially in the hospital, especially if I've got residents or other students with me. Lasix is not nephrotoxic. Okay, just put it on a t-shirt. Just remember that. All right, so I put this schematic up there to kind of highlight what I was talking about with loop diuretics specifically. So loop diuretics work, if you can see on this, where the blue arrow is pointing on the ascending limb of the loop of Henle, hence why they're called a loop diuretic. They work on the luminal surface of that part of the nephron, so the inside of the tube, all right? So, and you've got to get enough medicine to where it works so that you have your diuretic response. Well, there are two things that determine how much medicine gets to where it works. It is how much medicine you give and how much medicine gets from the bloodstream through the glomerulus and into the nephron and into Bowman's space. So if you have a patient that has a depressed GFR, be 30, 35, 25, 20 milligrams of Lasix is not going to get where it needs to go, all right? So they may need to be on 80. Heck, they may need to be on 160, okay? So it is recommended that you just increase how much you're giving them until they say, oh yeah, now I'm going. Now I'm having a diuretic response. All right, so our next line, at least especially in patients who have kidney disease and especially in patients who have proteinuric kidney disease, are our ACEs and ARBs. And this is, I don't know how it shows up, it's a little blurry on my end, but just a brief overview of the renin, angiotensin, aldosterone system. So renin is produced from the kidney, often as a response of decreased renal perfusion, all right? Converts angiotensinogen to angiotensin 1. That is then converted to angiotensin 2. Angiotensin 2 is where the money happens, okay? This entire pathway, the sole purpose is to increase blood pressure, okay? And so what we want to do is block aspects of this pathway in hopes of reducing blood pressure, all right? Angiotensinogen 2 works in 3 key ways. It causes direct sodium retention and therefore water retention in the kidneys. We discussed, how being hypervolemic leads to hypertension. It causes direct vasoconstriction of our vascular system. And then it also causes aldosterone release from the adrenal glands, where aldosterone then in turn causes further increased sodium resorption, further water retention, and further increased arterial pressure, okay? The medications at our disposal that affect this pathway, we're all probably very familiar with. So our ACE inhibitors try to block the conversion of angiotensin 1 to angiotensin 2. And our ARBs, or angiotensin receptor blockers, work on the very downstream parts to not allow these active molecules to even bind with receptors to cause their results. And then I'll mention further slide, but while I got it up, our MRAs, or mineralocorticoid receptor antagonists, so spironolactone, eplerenone, things like that, work to directly block the aldosterone effects that this pathway produces. Okay, so you've achieved euvolemia with proper diuretic use, and now and the patient's blood pressure is still not at goal. So my next, in the patients who don't have a contraindication, ACEs and ARBs, I don't have a preference necessarily over an ACE or an ARB. I personally tend to use losartan, but if you're more comfortable with, say, something like lisinopril in your patients, that's not a wrong choice. You have to be mindful of hyperkalemia, and often, I'll have patients ask or read that that their their GFR is dropped after stopping these medications. However, these medications also are not nephrotoxic. Okay, the way they work is they reduce tone on the efferent arteriole of the glomerulus, therefore reducing pressure within the glomerulus itself. So yeah, it's not going to filter as efficiently at a lower pressure. However, what we're doing is we are saving those glomeruli long-term and not letting them scar down and fully collapse on themselves to where you are going to get a permanent decline in GFR. So when using these medicines, it's usually a good rule to push the dose until you see a patient's creatinine bump a couple tenths or so, not double, but bump a little bit. It should make you feel pretty comfortable that you've gotten them to a pretty good dose. Contraindications, pregnancy, and then especially ACEs obviously have a risk of angioedema. Not common, but I for sure have seen it. And so you warn them about lip swelling, throat swelling, that sort of thing. Tell them to go to the hospital immediately. Our next line of medications that, especially that I use, are calcium channel blockers. If you remember, there's two big classes of calcium channel blockers, the dihydropyridines and the non-dihydropyridines. The recommendation is to pick a dihydropyridine. Amlodipine, nifedipine, felodipine. They do not have an effect on reducing proteinuria. And they do also have a fairly common side effect of peripheral edema. I see it quite often. I typically don't have to stop these medications because the edema is that bad. I might need to increase use of diuretics. But there are times where patients say, I can't even get flip-flops on, I'm not taking that drug anymore. All of them have that potential side effect. And then literature will tell you some headaches and flushing. I don't get that complaint near as much. Now, the non-dihydropyridines, such as verapamil and diltiazem, they may actually have a reduction in proteinuria, not near to the level as your ACEs and ARBs and other medicines. So I wouldn't necessarily pick those just for that reason. They can contribute to bradycardia and they can further exacerbate or cause a decrease in cardiac output. I personally don't think that I've ever started a patient specifically for blood pressure management on a non-dihydropyridine. And then probably your next fourth line are the MRAs that we discussed, spironolactone, eplerenone. I find these to be extremely beneficial in patients who have very resistant hypertension. Because of their effect on the RAS pathway, they will further reduce proteinuria. They can be used in conjunction with an ACE or an ARB, but you have to be even more mindful of hyperkalemia and close monitoring if you decide to use both of those classes. And again, because of its effect on the RAS pathway, you may see a more reported reduction in GFR. And that, again, is not a reflection of damage to the kidney itself. All right, and then some of the other classes just touch on beta blockers. Very often used, not only because can they be pretty effective in blood pressure control, but they're also, first line for patients who have CHF or other cardiac issues, which many of my patients do. I pick carvedilol, but again, that's kind of my personal choice. There's not necessarily one better, quote unquote, better than the other. I just anecdotally feel I get better blood pressure control with carvedilol. The alpha blockers, tamsulosin, doxazosin, I've never started for management of blood pressure. Obviously, I use it all the time in patients who I believe might be having issues with bladder outlet obstruction from BPH, and especially in an older generation. So I always take a good history about, obstruction and lower urinary tract symptoms and use them for that. But it is why they're usually recommended to take at night, because they can pretty dramatically drop your blood pressure. And then medicines like clonidine, hate clonidine, not ideal for long-term control due to frequent rebounds. So clonidine, very effective in getting blood pressure down pretty quickly. It also wears off pretty quickly. And you'll have patients that'll tell you that, their blood pressure was 190. So they took a clonidine, 2 hours later, it was 210, and that they're fighting this roller coaster. And almost without fail, they're on clonidine. And then it's kind of a dirty drug, just makes people feel pretty bad, can dry your mouth out, headache, fatigue. So if at all possible, if I am managing a patient's blood pressure or cleaning up their blood pressure regimen, one of my first goals is always to get them fully off of clonidine if possible. A few others, so isosorbide, again, not necessarily indicated for the management of blood pressure per se, can be used in conjunction with hydralazine in patients who have CHF, especially those who can't tolerate an ACE or an ARB. It's both a venous and arterial dilator. And then some further direct vasodilators, hydralazine, minoxidil. Issues here, hydralazine is usually 3 times a day, so you can have issues with compliance or adherence rather. And then minoxidil also very often can get complaints of edema, lower extremity swelling, fluid retention, those sorts of things. So other classes to think of if you've really exhausted and pushed the first 4 or 5 classes to really good doses and you're just still not getting there. There are options, but they're not, in my experience, there's not many patients I need to go to those lengths to get their blood pressure under control. All right, so a few take-home points. Hypertension's leading cause of chronic kidney disease. We didn't talk, I didn't have a slide on this, but it is important to be sure we're getting accurate blood pressure readings. Recommendations or patients come in, feet flat on the floor, usually in an armchair for about 5 or 10 minutes, put the blood pressure cuff on, have them hit the button, and then more importantly, write these down and keep a log, okay? It's also important for the very initial assessment to make sure you're getting blood pressure readings in both arms, perhaps even in the ankles as well, just to make sure that they're consistent in all limbs. It's not uncommon to miss, say, aortic stenosis or something, or pick up on something like that, and if you don't do the proper eval up front. Don't be afraid to start multiple classes of medications. They will need it, okay? If they come in with a blood pressure, and the first time you see them, it's above 160, 170, you're not getting them down with the diuretic alone. You're probably not getting them down with 2 medicines. It's probably going to take 3 or 4. So I would say do not be afraid to first time visit, start them on multiple things. I know Dr. DePetty is on, and I think he and I disagree perhaps a little bit on this particular point. I do not like using these combination medicines. I do know that it's helpful in patient adherence when they only have to take 1 pill with multiple meds. So for me, and it's mainly just a personal thing, if I ever want to adjust one med or the other, having them on a combo pill obviously makes that a bit more cumbersome to do. But I think the new recommendations or new guidelines strongly encourage, or at least encourage, use of these combo pills. That's just an aside. And then remember to treat the total patient, okay? And so when you're picking your meds, look at their other comorbidities. Do they have coronary artery disease? Do they have heart failure? Have they had a stroke in the past? Obviously make sure that we're watching for proteinuria. Are they diabetic? So that you can kill multiple birds with one stone, so to speak, in the regimen that we pick. And as I hit on pretty hard, I think you've got to watch for proteinuria. Not only that, you need to be measuring proteinuria every time every time you see them. And so if you're checking labs and getting, looking at their electrolytes and chemistries, you should be also following their amount of proteinuria, and it can be done with a PCR, or a protein creatinine ratio, just a single urine sample. I think I've got one more slide, and then I'll give it back to Vicky. But again, I'm not saying that this is what every patient needs to be on, but this is just what I found is good for a very large number of patients, especially that referral that says, no matter what anyone has done, no one has been able to get my blood pressure down. And to this day, I've yet to find a blood pressure that I can't get at or near goal with enough time. Okay, so since most of my patients have relatively advanced kidney disease, I'll put them on a loop diuretic just from the jump. Obviously, that dose will be adjusted based on what their GFR is. It does, at least once a day, but if needed, increase the frequency. And they may only need it every other day, or they may only need it once or twice a week. So you can play with that. I start losartan as my ARB of choice, typically at 25 to 50 milligrams. I know that it is a once a day dosing typically, but for me, I also want to make sure I'm spreading out my regimen across the course of the day, so that so even if I'm not getting perfect control yet, if the next time they come see me that they're at least consistent throughout the day, then we can just push doses up. Nifedipine is my calcium channel blocker of choice. Again, I also know that it's typically once a day for the same reasons I just said. I use it twice a day. I'll often start at 60 twice a day, sometimes keep them at an earlier dose of 30. I'm not afraid to go 90 twice a day, sometimes even higher than that if I need to. My beta blocker of choice is carvedilol. I'll often just go for the full 25 twice a day. If you notice that they're already a bit marginally bradycardic, or their heart rate in the office is already only 65, maybe you're not as aggressive from the beginning, but don't be afraid to be if you think they can tolerate it. And then I'll usually put them on that and get them to come back, and then add something like spironolactone if I think they're not at high risk for hyperkalemia and if they still need it. All right, so